Hello, good morning, good afternoon, and good evening to all our speakers, shares, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from the USA, Professor Alok Sharan. Dr. Sharan is the president and founder of the Spine Performance Institute, a practice devoted to providing personalized and holistic care for individuals who suffer from spinal disorders. He is a pioneer of the awake spine surgery procedures, the latest advancement in MIS surgery. He is a leading authority both nationally and internationally on awake spinal fusion procedures, having been invited to give presentations throughout the United States and many countries worldwide. He has held the leadership positions in his careers, like he served as the co-director of the WestMed Spine Center as well as chief of orthopedic spine center at the Montefiore Medical Center. He has received numerous academic distinctions for his research with over 100 publications, abstracts, and book chapters. He has co-edited a textbook entitled Basic Science of Spinal Diseases, and he currently serves as a deputy editor for the publication Clinical Spine Surgery. We are extremely honored to have him today at our webinars, and today we will be talking about rapid recovery spine surgery via awake spinal fusion. The speaker for the second session of today is our honored guest from China, Professor Wei Lang. Prof. Lang is the Associate Chief Physician at the Department of Neurosurgery at the Shanghai East Hospital, Tongji University School of Medicine, Shanghai. He is an expert in the field of cerebrovascular surgery, and we are extremely honored to have him today at our webinars. And today we'll be talking about application experience of a big bore catheter in thrombectomy. The chair for the first session of today is our honorable senior faculty from Istanbul, Professor Mehmet Zileli. Professor Zileli was the professor of neurosurgery, Department of Ege University, Izmir, Turkey. He was the past president of the Turkish Neurosurgical Society, Middle East Spine Society, World Spinal Column Society, and chairman of WFNS Spine Committee. Currently, he serves as the chairman of the Education and Training Committee of the WFNS. He is the co-founder of the first spine fellowship program in Turkey that has served many national and international fellows. He is a member of 13 national and 17 international medical societies, and he is the editorial board member and reviewer of 23 scientific medical journals. We are extremely grateful to him for accepting an invitation to chair the session of Professor Alok Sharan. The chair for the second session of today is our honorable faculty from Japan, Professor Shinichi Yoshimura. Professor Yoshimura is the professor and chairman, Department of Neurosurgery at the Hyogo College of Medicine, Japan. Professor Yoshimura was the past president of the Japan Society of Neuroendovascular Therapy and is a board member of the Japanese Society of Neuroendovascular Therapy, the Japanese Neurosurgical Congress, and counselor of the Japanese Stroke Association. He was the past editor of the Journal of Neuroendovascular Therapy, and he was the president of the Mount Fuji Congress as well as Japanese Neurosurgical Congress in the past. He is a noted researcher and author of the famous trials like Rescue Japan Limit Trial, and we are extremely grateful to him for accepting the invitation to chair the session of Professor Wei Lang. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this podium to our first chair, Professor Mehmet Zileli.
Thanks for very nice introduction. Actually, this is a really interesting topic that we will talk today on the awake surgeries of spine. During the last 20 years, we have many improvements in spine surgery, especially minimally invasive surgeries. So it would be hard to improve our operations without having new anesthetic techniques and without having day surgeries. It's now covering our daily practice to make some day surgeries. I'm sure Dr. Alek Sharan will tell us very valuable insights into the awake surgery and day surgeries of the spine. Yes, Dr. Sharon.
Thank you. And let me share my screen. Thank you very much for this honor, Professor Raja, Professor Zileli. It's truly a pleasure for me to present my my work on awake spine surgery, and I'm very excited to also just continue this conversation. As Dr. Zileli just mentioned, there's been tremendous advancements in spine surgery. And what I'd like to do for the next half an hour or so is talk to you about how we have been using our awake spinal fusion protocol to help achieve a rapid recovery in spine surgery. And as previously mentioned, we have seen tremendous advancements in spine surgery. I think over the past 10 or 15 years, we've seen some major, really advancements in spine surgery that's really changed the way we can practice. Items such as robots and navigation are really allowing us to place instrumentation in a safer manner. And I think that the more advanced minimally invasive techniques are really helping us achieve results which we never really thought we could be done before. But there is still a lot of room for improvement. There are still issues of safety involved in spine surgery, and not just the issues related to the actual spine surgery itself, but also related to the issues of surgery in general and the complications that we see. And from my perspective, there are so many patients who can be aided with spine surgery who cannot undergo spine surgery because of the issues of safety. It's been said that spine surgery is one of the more painful surgeries to undergo. It's listed as one of the top 5 painful spine surgeries. And it's because of that pain that prevents patients from undergoing surgery. But not only that, the pain from after surgery leads to slow recoveries, which leads to further complications. So the pain from spine surgery itself is a major problem. And then, of course, there's the issues of recovery. As I mentioned previously, pain, of course, is a problem, but there are other things too. And we've seen that patients develop nausea and vomiting and constipation and other symptoms which really prevent them from getting back to the way they want to do. So it's really because of all these factors that help motivate us to look further beyond just our surgical techniques to see how we can improve the overall experience of spine surgery. Our awake spinal fusion protocol has been focused on making spine surgery safer, less painful, and leading to a more rapid and faster recovery. Personally, for me, one thing I want to mention is that as I go through this talk today, I want to emphasize that what I'm going to discuss is really a rapid recovery protocol. It's not just one single technique, but it's really a protocol. And the goal, of course, has been to have patients recover faster, mobilize quickly, with overall less pain. This is our protocol, and I'll get into more detail later. But the essence of what we're trying to do is start with selecting our patients and educating them properly. I'm going to discuss briefly how we're using IV nutrition, IV infusions and nutrition as well, how we've converted to doing our surgeries under spinal anesthesia, describing the use of a new regional block called the TLIP block, and then using minimal narcotics post-op. It's really all these steps together is helping us achieve our rapid recovery. At this point now, we have done over 200 awake spinal fusions. On average, when a patient undergoes awake spinal fusion, they're less likely to be in the hospital. Our average length of stay is about 0.5 days, and that number keeps on going down. 60% of the patients who we do spinal fusions on go home the same day, and that number is increasing. And now we're at the point where we're essentially trying to be opioid sparing, where 70% of our patients are off of any kind of opioids or narcotics in 1 week. For me personally, the journey in creating this protocol started about 10 years ago when I was involved in this study. Amanda Tao, who's listed as the first author, at the time was doing a PhD. Her mentor, Joe Verghese, the last author, had noticed that many patients after orthopedic surgery, hip and knee replacements, would come into his clinic having developed delirium. And trying to understand why these patients were confused, we realized that it was the issues of general anesthesia. That when elderly people underwent surgery with general anesthesia, they're more likely to develop delirium. And that's a problem because as we move towards more day surgery, we realized that these patients would go home, they would be confused. And in this study over here, you can see that many of these patients would be readmitted to the hospital because they fell. And so we started asking ourselves, do we need to be doing all of these surgeries under general anesthesia? And is there a chance that we could start to use more regional anesthesia? Awake techniques have been discussed for many years. Awake brain surgery is very common. Hip replacements and knee replacements are being done as awake. So the question is, in spine surgery, why couldn't we do the same? And so we converted all of our lumbar procedures from general anesthesia to spinal anesthesia. And we had to work through our protocols, but at this point now, every lumbar procedure I do is performed under spinal anesthesia. We first started by performing our laminectomies under spinal, and when we went back and reviewed our data, we're shocked really to see how profound a difference there was in the pain that people experience after surgery. So just by converting from general to spinal anesthesia, we found a significant reduction in how much pain they experienced and how much medicine they needed to use. So in looking at this, we were really motivated to think, okay, what benefits can we have? I mean, we did a study published in the AO Spine where we showed that even when we do this, tremendous amount of cost savings by just converting from general to spinal anesthesia. So we realized at this point there is tremendous amount of benefits for converting over to spinal. There have been many publications that have been performed looking at this. So the idea was not a new idea, but I think coupled with the fact that patients are looking to leave the hospital sooner, it was an idea that needed to be readdressed. I mean, the truth is that regional anesthesia in surgery in general has been discussed for over 100 plus years. And the first reported spine surgery under spinal anesthesia was published in 1959. So the question is, why aren't we doing it now? And so we did, and we converted. And just to be clear, there are different ways that you could do regional anesthesia. You could do a spinal versus an epidural anesthesia. We found that when we perform spinal anesthesia using isobaric anesthesia, there's a more predictable onset and then completion. So as we're trying to move towards more rapid recovery, it's important that we can give the anesthesia and have it wear off in a predictable manner. It also requires a lower dose of medicine. Spinal anesthesia is a little bit harder to perform, and there is more risk of a post-dural headache. But we found that at this point now, spinal anesthesia with isobaric is better. Epidural anesthesia is more common. I think more anesthesiologists are familiar with it. But the problem is that it's a less predictable onset and there's a higher dose of medicine involved. So overall, to me, it's less efficient because it's less predictable. It is easier to perform it and less risk of a post-dural headache. But in my experience, if you're going to start an awake spine surgery program, I would recommend using isobaric spinal anesthesia. So as we became more comfortable with our spinal anesthesia protocol, the question was, why can't we use it to perform spinal fusion surgery? And I was thinking about this question for a long time and discussing it with my team. And then this patient came into my office. This is a female in her 70s. She was a widow. She previously had shoulder surgery under general anesthesia. She had developed delirium. She lived by herself. Her family lived too far away. And it was interesting because she knew that she needed to have spine surgery. She had gone through all conservative measures. But the reason why she was holding back was not because of the actual spine surgery, but because of the anesthesia. I discussed with her how we had been performing our surgeries under spinal anesthesia, and would she be willing to undergo her spinal fusion surgery with spinal? And she enthusiastically said yes, because she understood critically the difference. And we did. We performed her spinal fusion surgery under spinal anesthesia, and it was uneventful. And thereafter, we began to do this more and more. And as we became more comfortable, we realized that when patients undergo spinal anesthesia, they can mobilize quicker. So this is a gentleman now who's in his late 40s and who we performed this spinal fusion surgery on.
That's the word on the street.
How many hours ago did you have spine surgery?
Like 2, maybe less, 1.5, less.
So we realized that it is possible to do spine surgery and have the patients mobilize quicker. And with that, we were encouraged. And when we went back and started looking at our data, we found that similar to our laminectomy results, when we converted from general to spinal anesthesia, there was about a 50% reduction in their pain. And that the patients were able to actually leave sooner. And just by reducing from general to spinal anesthesia, there was a significant reduction in their length of stay. And this result has been corroborated. At this point now, I have many colleagues who've published their results, and we're seeing that there's about a 50% reduction in length of stay from just converting from general to spinal anesthesia. But really a big landmark for me came when I found this paper published in 2015 from Canada. This is a study published by Dr. Hand, and he had published or reported on a new regional block called the TILA block, the thoracolumbar interfascial plane block. This is a block that basically utilizes the interval between the multifidus and longissimus muscle. This is where the branches of the dorsal array might innervate. Using ultrasound, what he's been able to show is that if you can deposit medicine into that interval, there's a significant amount of pain relief that patients experience after surgery. We began to incorporate this block, and this is me. At this point now, I do my own TILA block using ultrasound. There have been many methods that have been described, but I personally perform it myself under a TILA block. And here's a video showing you this. Just to get you oriented, you can see the spinous process over here. You can see the multifidus muscle over here, and you can see the longissimus. As you begin to perform this procedure yourself, there are many things that you can note. One is you can really see the nice plane over here. The other thing to note is that when you're trying to find the difference between the longissimus and the multifidus, because the planes are different, you can see how you can see the muscle over here looks different over here. So this is how you can identify exactly the area to go to. And in this picture now, you're going to see in a second the needle coming in.
0.5 cc's.
So you're a little above the 10.
So go to 9. Go all the way.
Getting resistant.
Try that now. How's that?
Now we're doing. You're at 9,
Yep, all the way.
8, 7, 6, 4.
So you can see here really nicely how the medicine basically is entering this interval over here. And what happens over time is that it flows down to the branches, the different branches of the dorsal rami. This has been significant. And what we also realize is that while it's critical to do this TILA block at a deep level, it's also important to do it at a superficial level itself, because the dorsal rami doesn't head up to past the fascia to the skin. And so in this video here, in a second, again, here's the spinous process. Here's the multifidus. Here's longissimus. Here's the needle. And then here is the skin and fascial layers. And here's the video.
You need 0.5 cc's.
A little bit resistant.
And you can see the medicine going in over here. So what we realize now is that when performing the tibular block, it's important to do both a deep block as well as a superficial block. If you do that, you get good coverage and good pain relief. There have been numerous studies that have been published on this. This is just one that was a randomized study using general anesthesia with and without the TILA block, and they showed that there was a significant amount of decrease in the pain, significant amount of narcotics required. In our experience, we found that when we began to incorporate the TILA block, we were able to bring our length of stay down to the point where we started thinking about outpatient surgery. Many of the patients, after they had the block, really felt no pain, and they began to ask us, this is earlier data, but they began to ask us, can I go home early? And because of that, we were motivated to realize that, yes, you could go home early, and we did start discharging these patients the day of surgery. But what's been interesting for me is this. We've been able to show now that the combination of spinal anesthesia along with a TILA block not only results in less pain and faster mobilization, but allows the patients to go home early. So now that we've been able to achieve outpatient spinal fusion surgery, we began to think, what should our next goal be? And currently my goal now is to make this surgery an opioid-free spine surgery. To do that, I began to look at the literature and try to understand what is it that patients require that leads to them having pain after surgery. And just looking at the literature and looking at other surgeries, especially orthopedic sports medicine, we found that nutrition plays a big role. Nutrition plays a big role because it helps patients recover faster, but there is a component of how inflammation during surgery or after surgery can lead to more pain. And that if you can reduce the amount of inflammation prior to surgery, I'm realizing now that that leads to a faster recovery as well. This was a study performed in 2021 that showed that basically the addition of a protein supplement actually improves the width of the paraspinal muscles. This is a randomized study, and they were actually able to show that by increasing the paraspinal muscle strength, they were able to help the patients recover faster. So with this study, we began to perform IV nutrition. And so prior to surgery, we give patients glutathione, which is an amino acid, which helps to reduce inflammation. We give patients an amino acid supplement, and then after surgery, we do that too. Glutathione helps to reduce inflammation prior to surgery as well as afterwards, and the amino acids helps to improve the muscle strength. What we're finding now is that by adding this combination, at this point, I've discharged our patients with just 4 opioid pills, which is helping them recover faster. So not only are they able to go home the same day, but really they're taking minimal pain meds after surgery. So you can see that with our protocol, we've been able to make it a safer procedure from converting from general anesthesia to spinal anesthesia, where by adding in the regional block as well as our nutrition supplement, we're able to minimize how much pain they have. And then by the fact that they're able to walk faster and leave the hospital quicker, we're able to achieve the rapid recovery to the point now where the recovery for a laminectomy and a spinal fusion is very similar. That's been really nice because I see that there are many patients here, especially here in the United States, that as they get older, the need for spine surgery will increase. The patients over 65 who need spine surgery, that the need will only increase. So I think it's upon us as surgeons to understand how we can deliver these surgeries safer and give them a rapid recovery so that they won't be afraid to have spine surgery. Here's an example of a lady who had undergone a single level fusion. She is in her early 60s.
I had an awake spinal fusion, and it was wonderful. It really was.
Good. Can you walk back and forth for us one more time? Good.
I had an awake spinal fusion, and it was. I had an awake spinal fusion, and it was.
This is her now 1 week later.
Good. Can you walk back and forth for us one more time?
Dr. Schron performed TLIF, transfemoral interbody lumbar fusion for my back. I was in a lot of pain before surgery. I really couldn't do anything, couldn't work out, couldn't exercise.
I like that I can stand.
Barely could sit for a long period of time or stand, and had a lot of pain, sciatica pain down my leg. Ever since the operation, I've been up and walking since day 1 of the operation, since a couple hours after the operation, and I've been nonstop ever since. No pain in my leg whatsoever. I totally recommend this surgery. I recommend Dr. Sharon. He has been tremendous throughout this entire experience. And anybody that needs this surgery, I suggest you take that.
And then this is 2 weeks later.
Hi, I'm Kathy. I'm 53 years old, and I'm a health and phys ed teacher for about 20-something years. I needed to get spinal surgery on my lower back because I was in a lot of pain, sciatic pain, and Dr. Sharon performed a TLIF, and it's 2 weeks after my surgery, and I'm feeling amazing. I can do basically everything. Things that I couldn't do before. I couldn't bend, I couldn't twist, I couldn't tie my shoes. I can do all of that now, plus more, and it's only been 2 weeks. I feel amazing, and I can't say anything more than Dr. Sharon was amazing. He did a great job.
So this is, you can see now, these are the kind of results that we're getting with these patients. I think by avoiding general anesthesia, they recover faster. They don't develop that haze, no nausea, no vomiting. Their recovery is overall better. There are tremendous advantages of converting from general anesthesia to spinal anesthesia. Patients have less delirium post-op. On the table, it's nice because the patients actually can position themselves. So the issues of vision loss or pressure sores are really minimized. After surgery, they have less nausea, less vomiting. There's better pain control, which is helpful. And of course, faster mobilization. We use the isobaric, and so we don't use a catheter. So it requires us to be very efficient in the OR because you have limited time for the spinal anesthesia. But I think if you have a good team, it's very easy to do. And depending on how you dose it, you can't do a proper neuro exam post-op. And so that is concerning. We do use neuro monitoring and do EMG monitoring during surgery. We validated that that is a valid way, but that is an issue after surgery. So there are tremendous advantages, and I think the advantages outweigh the disadvantages. So to conclude, our rapid recovery spine surgery protocol starts with just proper education of the patient, helping them understand what we're doing, why we're doing it. We then do an IV infusion of glutathione, both before and after surgery, to reduce inflammation. In addition, we give them nutrition supplements to help improve their muscle mass. I perform my lumbar infusions minimally invasively. We use the isobaric spinal anesthesia. We use a TLIP block, as I mentioned earlier, and at this point now we give minimal narcotics. All that together helps us achieve the rapid recovery spine surgery. As I mentioned before, we've done over 200 of these cases. Our length of stay at this point now is about 0.5 days. About 60% of patients are able to go home the same day, and about 70% of our patients are off of any narcotics within 1 week time. So with that, I wanted to thank you again for the invitation. Look forward to our.
Thank you, really. It was a great talk, really very nice technique. I read one question from Dr. Harshad Tarek. Does the more number of levels of the compression and fusion decide about selection of anesthesia?
So if the number of levels, of course, increases the amount of time you spend in the operating room, and so then we just dose it properly. In general, we basically think about it as you should have surgeries that are less than 3 hours when you're performing it. I think that patients cannot tolerate being prone for more than about 2-3 hours. So depending on how long it takes you to do the surgery, we'll do that. I've done up to 2 levels of lumbar fusions now under spinal anesthesia. There have been reports in other parts of the world that have done more than that, but I personally have never done more than 2 levels.
Yes, maximum 2 levels, you say.
Yes.
What about, does spinal anesthesia reduces bleeding during surgery than general anesthesia?
Yeah, that's a great question.
Is there such an effect? I don't think so.
I don't think so, and I don't know if there is any kind of vasodilation effects. Because we're doing the surgeries minimally invasively, we don't really lose much blood. So I think it'd be very hard to study that question. I don't think I have a good answer for that because I haven't noticed any major difference.
You know what? I also use similar technique, spinal anesthesia for lumbar fusion. Although even if it is not a minimally invasive open surgery, I do maximum 3 levels. And if it is more than 3 hours, we can make rappel injections during surgery.
Right.
Because everything is in front of us, then we can, it's not difficult to make a new injection.
Yes, and we've had to do that just a few times where if the surgery ended up being a little bit longer, you could do a direct spinal at that point, because just like you said, that the dura is right there, so it's really not that big of a deal. I think the biggest restraint more is just the patients being prone and how long they can tolerate being prone.
Yeah, right. Exactly. Yeah, actually, some patients may not be tolerating that, which is very hard to manage.
Exactly.
Because of that, you are educating, training the patients before surgery. Do you?
That's critical because we have to ask the patients, how do you feel about that? How do you feel about being prone, and does that bother you? So we have to have that discussion. They can't be surprised. In discussing our technique, I've had a chance now to discuss our technique and present across the world. And I was speaking to colleagues in Nigeria, and for many of them, that all they do, because they have limited anesthesia machines, they don't actually do many of their surgeries with general anesthesia. They do it under spinal, and so the patients just expect it that way. They expect to have their surgery awake, not under general anesthesia. So I think it's a lot about how you discuss it with the patient beforehand.
Dr. Sharon, what do you think about the using just local anesthesia for some spine surgeries instead of spinal anesthesia. Yeah, under spinal anesthesia, you are very comfortable because the patient feels nothing.
Correct.
What about local anesthesia? I've seen some surgeons not very, the numbers are not much, but there are even some papers doing spinal anesthesia under local anesthesia, cervical spine surgery.
There's
What do you think about this?
There was a paper from Turkey where they did an ACDF under local surgery. I mean, they do carotid surgery under local. I would be really curious to see with ACDF if we can make that under local surgery because of that. I think the issue is when you have to move the trachea for the surgery, how do you handle that during surgery? but in posterior cervical, I think it's been commonly reported. With lumbar, I think what's the interesting question with lumbar is, do we need to do spinal anesthesia? Because when we do the regional block, the TLIP block, it blocks the dorsal rami. But if you go deeper, you can do a block such that you get both the ventral and the dorsal rami. And when we do the block, generally it covers about 2 levels above and below. So there's crossover. So I think the interesting question is that can we just do, let's say, a TLIP block deeper, block the ventral and the dorsal rami, and we don't need to do a spinal anesthesia. And
what about, what is your highest level of application surgery for spinal anesthesia? For instance, L1-2 disc herniation. Would you consider making a spinal anesthesia?
That's the highest level that we would go to because the anesthesiologist won't feel as comfortable. They don't like it. You could do it because they do T4 blocks, for C-sections, for breast surgery. They do that. If you have a good anesthesiologist, and I think that because we use isobaric, the risk of respiratory depression is not significant. Hyper, of course, is the issue. I don't think there's any issues at all if you do L1, L2 and you use isobaric anesthesia. You just have to have I think the bigger problem is just getting the anesthesiologist to change, to be comfortable with it.
Yeah.
That's always a challenge.
Yeah. I thank you a lot for very nice presentation, a good technique, and very nice discussion at the end.
Thank you very much.
Thanks a lot.
Thank you for the invitation.
Well, thank you very much for this wonderful presentation. We enjoyed a lot and learned a lot. Thank you, Prof. Alok Sharan. And now it's time we'll move on to the second session. And before that, I would like to inform our viewers and honorable faculties that this has been broadcasted on WeChat, YouTube, and Zoom. Thanks to Professor Shubin. And now we have around 413 people who have logged in through all different channels. So we're extremely grateful to Prof. Shubin. So now we'll move on to the second session. So I'll hand over this podium to our second chair, Prof. Shinichi Yoshimura.
Hi, hello everyone. I'm Dr. Yoshimura from Hyogo Medical University of Japan. Today, we are happy to welcome guest. Today's speaker would be Professor Len. He's going to talk about his experience of a big bore catheter for aspiration thrombectomy. We are really looking forward to his lecture. So please start your lecture.
Thank you very much to introduce me. Good evening. My name is William. It's my great honor to participate in this ACNS webinar. Thank you very much for your invitation from Professor Xubing and the Professor Rija. Today, the type of my lecture is experience of use big bone catheter in thrombectomy. First of all, allow me to introduce our hospital location. My hospital have two campus area. The north one is located in the Lujiazui area of Pudong New area, Shanghai, with more commercial and office building around and reality feel recent. So there is a few thrombectomy in my north area hospital. About 40 cases thrombectomy every year. And the south one is located in the south of Pudong New area with relative more thrombectomy. Presently, the total operation volume into area is about 113 cases every year. In the past, thrombectomy at my hospital began in 2013. At that time, we had only one guided cancer is envoy. We use 6F envoy, but it can only reach to the C1 segment of the interartery into ICA, and thrombectomy was performed use solitaire stent. After release the solitaire on occlusion site, the thrombus may be crossed by the stent, then escape to the remote visual branch. Then we need to perform the same procedure again. It spends us much more time, so efficiency is very low. However, before 2050, all the clinical research about mechanical thrombectomy in treating acute ischemic stroke is a negative result until 2050. 5 clinical research articles were published at the same time in the New England Journal. It is interesting to note that all is a positive result. Therefore, guidelines of the treatment of acute ischemia were updated both in United States and China. Mechanical thrombectomy has been established as the standard treatment for acute ischemic stroke due to the larger visual occlusion in 2012. In the past, the main question was, do we need to perform the mechanical thrombectomy? And now, the main question is changed to how can mechanical thrombectomy be more effective? Now it changed to how can mechanical thrombectomy be more effective? In 2017, we can get a kind of navy cancer. It can reach ME segment of MCA, reduce the blood clot escape problems, but because 5F cancer is thinner, so blood clot could not be removed quickly. The efficiency is improved, but haven't reached our requirements. This is a case of thrombectomy performed in 2017. The angiography, you can find the left MCA was closed. Firstly, we performed introduce this is a long sheet, and we perform the navy cancer to the C2 segment of the ICA. Then we introduce the micro cancer and micro Y to cross the occlusion side. This is the micro Y across the occlusion side. Then we approve another micro cancer to the remote branch of the normal visual. Make sure the micro cancer in the normal visual. We deliver a standard subscriber to the occlusion site. And but we cannot recognize it at the first time procedure, and then we perform the we cannot recognize it and perform the second and the third procedure. In the end, it took us about 15 minutes to recognize the visual. For the patient with acute cerebral ischemia, this time is too big long. In fact, our ultimate goal of mechanical thrombectomy is the achievement of the complete reperfusion in a single attempt in a short time, which have been reported as a strong predictor of better clinical outcome. So we need a new catheter. But the size of the catheter is a trade-off, and each inside the dinner should be larger, and its tip should be soft enough. Avoid the artery collapse that may lead to vasospasm. Also, it should have the good navigability, trackability, which is the ability to advance to reach the target side, and pushability, which is the ability to transmit a push forward from the proximal to the distal end the device. And in this case, we use the aspiration catheter, also named the intermediate or distal access catheter, to reach the top of the base of the artery, and we use the direct aspiration technique. Successfully, recanalization was achieved in 10 minutes. It benefits from the big bone aspiration catheter, and the use of aspiration catheter drop us from the adapter 1 area to the adapter 2 area. Aspiration catheter can be navigated easily through the vascular anatomy to reach the occlusion site quickly. This is the catheter we can get in our hospital. The Navy have a good spot, and the Reactor 68 have a good software, and the reliability is better than Navy catheter. And Reactor 17.1, both spot performance and reliability are excellent. In this case, it's 8 years old female, because of the black stool for 3 days, was checked in the cardiologic department. Because he have a long time hardness after PCI, so black stool was related to long-term oral aspiration. So stopped using aspirin during hospitalization. After the therapy, the stool color was gradually returned to normal, and at the discharge day, suddenly onset of left limb weakness. And this CTA, we can find the right MCA was disappeared, and angiography. We can also find the right MCA was disappeared. Because of the advanced age, blood visual totals, the transfemoral access was very difficult. So we use the radial artery puncture access. Firstly, we place one 6F sheath in the right ICA. And this video we can see the Reactor 71 can smoothly from the C2 segment to the ICA same segment without any guidance of all spot. After the aspiration catheter reach the occlusion site, ensure that aspiration catheter is close to the clot. Then we use the direct aspiration technique suck out the blood clots. This is thrombus in the aspiration catheter. The right MCA was recanalization. Another case is female and 18 years old. Weakness of the right limb for half an hour, and he is healthy and denied hypertension, diabetes, and chronic heart disease. And CT scan we can find abnormal scan. In this video, we can also find the Reactor 17Y. It's a kind of big bone, the big bone catheter, aspiration catheter to the siphon segment of the ICA. And large bone aspiration catheter also have a successfully trackability to negative smoothly through total visuals in order to reach the site of occlusion. We draw after release the standard retriever on the occlusion side. We withdraw the standard retriever in the aspiration catheter. In this case, we use combined mechanic thrombectomy technique. It means that we combined with the standard retrievers. And after operation, we can find the left MCA was recognition. And after the discharge day, in 7th later operation, his left limb muscle strength was grade 5, and the right limb muscle strength recovered to grade 4. And another case is male and 3 years old, weakness because of weakness of left limbs of half an hour. And he is healthy in the past, denied hypertension, diabetes, coronary heart disease, but emergency ECG, you can find it has ectopic rhythm, atrial fibrillation, and the left limb is grade 1, the right limb muscles strength is grade 1. This is 15 and this is 13. And as you we can find the left MC was closed. And in this video, we also can this aspiration catheter can smoothly reach the two siphon segment from the C1 segment to the siphon segment of the ICA. The micro catheter is then checked further over the micro Y2 across the occlusion side. And under the navigation of the micro catheter and the micro Y, reactor catheter can reach the M2 segment of MCA. And then we make from the micro catheter is in normal branch in the distal branch of the MCA. We deliver the stand to the occlusion side. This is a standard retriever. Under the after the deliver the cloud we navigated the aspiration catheter over the rail to the proxy interface of the thrombus. And this in this case we use a save technique. It means that the simulators retrieval of the stand traverse and distal access catheter on the continuous aspiration. And after the operation, the right limb recovered to grade 3. And this is another case, is male, and it is 45 years old. Because of the heart disease and the performance heart operation on February 2018. And the 4th days heart disease, the heart surgery later, suddenly he cannot talk clearly and feel weakness of the left limbs. And the CT scan, we can find the right MCA was occlused. And this is angiography. the standard driver is deployed over the cloth, and from this stand mark, we think that the thrombus is stuck in the stand. Then we draw the stand and the thrombus at the same time. Only once attempt we recognize the visual quickly, and this perform operation, and MC was recognized, and this is thrombus in the aspiration cancer. The last one case is a male 65 years old, and because of weakness of right limb for half past 2 hours, and he have a high blood pressure and diabetes for many years, and the CT scan CTA showed that the left in ICA was poorly delivered in the whole process. And from the angiography, we think that this is a tandem occlusion. We suppose the middle MCA, the MCA thrombus is secondary to the ICA stenosis. We would firstly pass through the occlusion of the MCA, pass through the region of the ICA artery, ICA, then remove the thrombus from the MCA artery. And this is the thrombus on the stent travel from the left MCA. And then finally we recognize the region of the region of the ICA. Because under the protection of the imbecile, we use a balloon to expand the ICA. And this video, we can show that his right limbs muscle strength can recover to grade 4. And at the discharge day, CT scan, we can find a small infarction on the left side of the basal ganglia area of cerebral infarction. We hope he covers better. In general, a large bone aspiration cancer can provide great aspiration force, and on this base, we can use various techniques to achieve complete reperfusion at once attempt in the shortest time, ultimately improves the patient's outcomes. In this group of patients, successful recognition was achieved in 19.2 of patients with complete recognition. Rate of 71%. Successfully recognition was achieved in a single pass in 54%. The median procedure time from artery puncture to recognition was 32 minutes, and the mean number of passes is 2. No procedure complication related to aspiration cancer were reported, and the final independence at 19 days was 42. And the new large bone aspiration cancer may be affected the ability of the aspiration cancer and achieve closer contact associated with greater frequency of single pass case and higher probability perfusion. Thank you. Attention. That's all. Thank you.
Thank you for your wonderful lecture. and sharing your wonderful experience with large bore catheter for large vessel occlusions. Several questions to you. So now we know that recent big bore catheter can be navigated to the MCA without any internal catheters. It's wonderful. So my question is, when do you combine this big bore aspiration catheter with stent retriever? In some cases, you combine with stent retriever plus big bore aspiration catheter. And the other cases, you aspirate the clot with the aspiration catheter only. When do you combine stent retriever with this big bore catheter?
Thank you. It's a good question for our clinic doctor. In fact, in some people, the artery is not very total. So we can deliver the aspiration catheter easily to the MC1 or 2 segment of MCA. But in some cases, if the artery is total and you cannot easily get the M1 segment of the MCA, this time we need to deliver the micro catheter or micro Y to across the occlusion side, and under the navigation of the micro catheter, we can navigate the aspiration catheter to the distal, probably proximal of the closed two side. And in the basal artery, it is strength more than the ICA. So sometimes we can get the basal tip of the basal artery tip and can perform the direct aspiration technique. But in ICA occlusion or the distal of the MCA, we usually need the combined standard retriever technique to achieve a higher pressure. Thank you.
Okay. Thank you. And my second frank question is, which is your preference? React 71 or 68? You
61.
introduced the React aspiration catheter 71 and 68. You have two kinds of React catheter.
71. 71.
71. Larger one.
Presently, we perform all the operation use React 71 because it is in the diameter, and the outside diameter is more large than the React 68. We think that the diameter is larger, then it can give us effect a larger aspiration force in the aspiration catheter, and it can get more effective to this operation.
Mm-hmm. My last question is, we frequently encounter ICAS-related occlusion in Asian patients, right? So in that case, ICAS-related occlusion, how would you treat?
In some case, if we if it has stonies, we need some we could use the balloon to expand the stenosis in the occlusion side, and in a few cases, maybe we need to perform the stent to perform the positive blood flow. Thank you.
Okay.
Sensei, there is one question from Dr. Ayman Ali Mas.
Oh, sure.
Can you please ask?
Yeah, thank you, Professor. Thank you for this magnificent presentation. My question is something basic. I saw one of the case that's 2.5 hours, and I think directly going for mechanical thrombectomy. Is your practice you use antiplase or recombinant tissue plasminogen activator if the patient came before 4.5 hours, or go directly to mechanical thrombectomy, or do you use IV and after go for the mechanical thrombectomy suite or suit? Thank you.
In some case, if the artery is not totally, we can use the direct aspiration technique. It maybe use less more time to get the recognition. So in the case 2, we use only 10 minutes to perform the perfusion.
Thank you.
Thank you very much. Yes, Michael.
Thank you, Prof. It was a nice presentation. If a patient came with tandem occlusion, ICA and MCA, so do you go antegrade or retrograde? Like from first do the ICA and then the MCA, or you do thrombectomy from MCA and go to the ICA? Which one is the practice in your setup?
In the last case, I showed it is a tendons disease. Usually, we need to firstly cross the ICA occlusion of the ICA region of the ICA, and firstly we perfuse the MCA. Then they perform the operation of the region of the ICA.
So we come to the end of this session, and we can hear the concluding remarks from Professor Yoshimura.
Thank you for sharing your wonderful experience with large bore catheter for large vessel occlusions. Your lecture was amazing, and I think everyone can do a similar technique for next day's experience. So thank you very much. We really enjoyed your talk.
Thank you very much, Professor Yoshimura and Prof. Weyland, for this wonderful session. So we'll now come to the end of this webinar, and I'd like to close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both speakers of today, Dr. Alok Sharan and Prof. Weyland, as well as the chairs, Professor Mehmet Zileli and Prof. Shinichi Yoshimura, for the time and support for the ACNS webinars. Yes, very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as I said earlier, we have around 415 people who joined us from all over the world. A special thanks to my co-host Dr. Liubun Singh for joining me today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.